Welcome to CardioSource Video News. I'm Dr. Randy Martin. ACC.10 and the I2 Summit 2010 provided us with some eye-opening studies and breaking clinical trials. While the conference lasted only 3 days, I'm sure we'll all take home important information that we can immediately incorporate into our practices. Now, we've had a team of blue ribbon experts providing analysis and perspective during the conference. We're going to go to that panel again. Joining me to my immediate left is Dr. Peter Block. Peter's professor of medicine and cardiology, as well as director of the structural heart program at Emory University Hospital. Peter, thanks for joining me. Next to Peter is Dr. Liz Clotis. Liz is the director of the cardiovascular imaging and cardiovascular imaging consultants in Minneapolis. Liz, glad to see you
nice
here.
To be here.
And rounding out the panel, Dr. Tony DeMaria. Tony's professor of medicine at the University of California at San Diego and also editor-in-chief of the Journal of the American College of Cardiology. So it's been an amazing 3 days here, really interesting time. Peter, let me start with you. Sort of, what do you see today that was hot, and also what are your sort of takeaways?
Well, today is a funny day. We have these 2 trials of acute myocardial infarction and stenting, and they're weird. I mean, dedication is the first one of these, and this is any bare metal stent against a drug-eluting stent. And it turns out that for target vessel revascularization, MACE, target lesion revascularization, all those things, DES did better than BMS, and yet cardiac death is increased over bare metal stenting. I don't get it.
I mean, what do you make? I mean, what do you
I
make
have
of
no
that?
idea, but PASSION, which is the other one, which used Taxus against bare metal stenting, showed no difference in cardiac death. So this is really sort of a strange dichotomy of 2 trials. Tony knows all about trials, so he'll tell us what the answer is here, but I can't figure it out.
Tony?
I have no idea.
Thank you very much. That's the last we'll hear from you. Trust me, I'm not looking at you again. So, seriously, what do you make of this?
Well, I think on the face of it, the 2 trials obviously don't agree, and one trial is inexplicable. So my tendency would be to go with the trial that has more pathophysiological basis and rationale, and probably PASSION is more in the correct direction.
Were there trials that are going on today that struck your fancy or things you learned?
Well, we're getting some additional data from Plato. You remember Plato is ticagrelor. A very effective antiplatelet drug that's rapidly reversible. And so what they did is they looked at the patients in the Plato trial and who were going to surgery. And, in fact, the patients who went to surgery had much less bleeding with ticagrelor than they did with clopidogrel. And so it proved the anticipated benefit, which was that a rapidly reversible drug would be better for patients going to surgery.
Super. Liz, what'd you hear?
You know, one of the there was a terrific poster actually that looked at obesity rates and LDL levels in children, middle school children, depending upon whether they brought their lunch from home or ate at school.
Interesting.
And the big take-home message is you can't trust a middle schooler to make good choices. It turns out the kids that ate at school, ate a lot more fried foods, fewer vegetables, less fruit, were more obese, had higher LDL levels. So it speaks to a couple of things. One is, probably need to do a better job in terms of what we're offering our kids at school. And 2, maybe sending your child.
Should we all pack little brown bags?
Yeah, think about what's in the doctor's lounge.
Yes. No better.
A lot of people I've seen look like they've been in the middle school line. So, Liz, you mentioned something else about, I'll come back to Tony and Peter in a second, about the vitamin D. You heard some interesting stuff on vitamin D.
There was a couple of interesting studies that came out of Utah, out of Intermountain Health, and they looked at, first of all, patients that were low in vitamin D to begin with, and then over time, some of them normalized their vitamin D levels. And when they compared the patients that normalized their vitamin D levels versus those that didn't, the ones that did not had worse outcomes, had higher rates of events, 30% higher rates of cardiovascular events. That's pretty amazing for something pretty simple to measure and supplement. The other study that came out of that group, besides reconfirming the fact that lower vitamin D levels have are associated with worse outcomes, did an interesting statistical analysis where they were actually able to get at what's probably the optimal vitamin D level that we should have, and it's actually around 43, not 30.
So substantially higher than what we're talking
Substantially
about.
higher.
Tony?
This may be a bit more of a complicated issue than we realize, because there was recently a paper, not in the cardiovascular literature, that has suggested that for black Americans, that in fact higher vitamin D levels lead to more calcification of their coronary arteries and perhaps more disease. So there may be a racial divide here in terms of vitamin D.
I have a question. Should we all go out in the sun somewhere? I mean, what does this really mean?
I mean, the research on vitamin D with multiple systems, because it's actually a hormone. It's got anti-angiogenic cell properties, all sorts of stuff. But I think, good balance, because Tony's saying that the whole data is not in. Right now, everybody says you need more. But there may be some differences.
So should we supplement this, Liz? Is that what you're saying? Or should we just go out in the sun some more? The dermatologists are not going to like that.
No, well, and if you put on a sunscreen with SPF of 15 or above,
you're done.
You're done.
But I think one thing is that for those of us that see women patients, because vitamin D is obviously important for
bone health.
Yeah, you need to make sure they have an adequate vitamin D intake or stuff like that. Tony, any other things from today, or as you look back at the whole meeting, what are your sort of take-home points?
Well, from today, of course, there was a trial comparing radial artery grafts to saphenous vein grafts. What's the better conduit? And although the overall results were negative, which is to say there really didn't seem to be any difference, there were some significant differences, as I recall, in terms of harvesting and the diffuseness of disease.
Now, tell me what you mean by that, or Peter, maybe you could.
Yeah, I've got the data. It turns out that the one-year patency rate is only 89%. We've always thought that at 1 year, saphenous vein grafts or radial grafts don't do very well. They don't. It's 10% of them are gone. The other interesting thing I took from this study was that if you endoscopically harvest a saphenous vein graft, the downside of that is that there's a far higher loss of that vein graft over the first year.
That's interesting.
So an open harvest may be the better way to go for a vein graft. Interesting sort of data.
Yeah, very interesting. Yeah. In terms of the whole meeting, Randy, it struck me that the message was that the enemy of good is better. And in fact, if we look at the ACCORD trial of lowering blood pressure, a little bit is good. A lot is not better. It's the enemy of better. If we look at heart rate control and atrial fibrillation, a little bit is really good, but too much doesn't buy you anything and may get you drug side effects. So something we often stress to our fellows, better is not always the way to go when you have good to start with.
Peter, you have a one-liner that we can come at Tony with.
Tony sort of took my one-liner. So what can I say? So I think my one-liner is probably pretty much the same. 50% of what we think we know, we don't know if we only knew which half.
Right.
I think that's okay. But I would say don't throw the baby out with the bathwater, because one of the issues here is we look at these trials that didn't come out to show us anything positive. If we take the broad brush and say you don't have to treat atrial fibrillation or you don't have to treat hypertension, and you take that message away, which is the wrong message, you have to remember that hypertension still produces stroke, and by lowering blood pressure, you significantly decrease stroke, and that was supported again by these trials. Yeah. So we have to be careful about broad brushing these outcomes quite so much, and remembering that it is the center of things, as you say, good is better than best, and trying to keep some balance as to how we go forward treating our patients.
Well, best might be better if you really got there.
Exactly.
But does it, we talked about this, does it simplify our treatment regimes in these patients? In other words, if we had added multiple meds or done multiple things to get to the best, and that's not necessary, it's a simplified approach. I mean, you were saying.
Absolutely. I think that the fact that we're going to be able to use fewer medications can't be bad. Yeah. And the patients are going to love us for it.
And of course,
go ahead.
Sorry,
go ahead.
And I was going to say, what's the thing that emerges for me is having to look at the whole patient. It's not just about, yes, we have to lower blood pressure. Yes, we have to lower cholesterol. But people have to have adequate amounts of vitamin D. They actually have to make good choices when they're choosing their lunch. So and some of that isn't always highlighted as much as some of these other trials.
Tony, you were going to
No,
jump in.
I was just going to say, again, we didn't mention it, but the dual antiplatelet, we didn't mention it because the data is really not very strong, but it was another instance where what they showed was dual antiplatelets really didn't produce a better end result than just continuing aspirin alone after 1 year.
Interesting. Are there things that you, and we've sort of touched on this, that you think people will incorporate into their practices right away? I mean, do you see things that might change the way we practice?
I think the atrial fibrillation business is going to change practice right away. I think
you talk about rate and ablation and all that stuff?
I think ablation, number one, clearly now ablation is better than drug therapy, particularly the cryoablation. Though I can make a comment about this if I can.
Go ahead.
Second, one of the things that we forget is that all ablation carries with it a low but definite risk of pulmonary vein stenosis.
Right.
And I will tell you, as an interventional cardiologist, to try and stent that or make those better is terrible. It's really difficult to do. The restenosis rate is very high. So even though it may only be 3 to 5%, it's a bad outcome. And then, therefore, to say it is relatively safe and therefore we don't have to worry about medicines anymore is probably not always the right approach. You always have to think of that bad outcome as being almost irreversible.
I was chairing a session yesterday on interventional echo, and I saw an interesting thing about three-dimensional ice. And, and we obviously 3D TE and guiding, actually looking at the pulmonary vein orifice and guiding, watching as you're doing this stuff. Kind of interesting. Tony, go ahead.
Following up on what Peter said, I think the cryoablation, the success rate, which was really impressive with that, really, I think will make many of us who've been conservative, who've said ablation is when you failed everything completely, absolutely, may push us to intervene a little bit earlier.
Super. Liz, let me finish with you. And so what's your sort of take-home message? What do you think about practice? About incorporating into our practice. Yeah.
I mean, not to sort of beat a dead horse into the ground, but low vitamin D is a cardiac risk factor. People should be screened for that and treated.
There you have it, ladies and gentlemen. Breaking news from our blue ribbon panel, and that's what you are. Listen, thank you, all of you, for being with us. This was really fun, and we've learned a lot. Always stay on CardioSource for the latest cardio news, science, and education.